My name is Lisa Schlager. I'm the Vice President of Public Policy with Force, and I just want to start off by welcoming you again and sharing a little bit about the Reducing Hereditary Cancer Act. So this legislation was introduced last Congress. It was reintroduced this Congress, both in the House and the Senate with bipartisan support. We don't know why most people get cancer. However, we've learned that a subset of cancers are caused by inherited genetic mutations that inhibit the body's ability to fight cancer. And individuals who are identified with these mutations really have an opportunity to either prevent those cancers or to catch them earlier when they're easier to treat and to cure. And the genetic testing for these mutations has really become the standard of care in medicine today. Over the past 25 years, it's really become something that's integrated into medical care and oncology. And it started with the BRCA1 and BRCA2 genes in the late 1990s, but due to medical and scientific advances, we now know of more than 24 genetic mutations that confer a moderate to significantly increased risk of cancer, sometimes as high as 80%. So the genetic testing and the recommended downstream care is typically covered by commercial insurers as well as Medicaid. However, we've learned that Medicare only covers this testing for beneficiaries who are diagnosed with cancer. So they have to have cancer to qualify for this genetic testing. And that's regardless of their family history. It's regardless of whether or not another family member has a mutation. So it really doesn't provide that opportunity for prevention and early detection. So the beneficiaries who come into the Medicare system, unfortunately, if they've already learned that they have a mutation and they've been getting the care they need under their either private insurance or Medicaid program, they have a disruption in their care continuum. They're no longer able to access those services that they've been getting before they became eligible for Medicare. And it's so important for these individuals, whether they knew about their mutation before they were on Medicare, or if they were able to access the testing by paying out of pocket or participating in research when they're in Medicare, for them to be able to access the increased screening and the risk-reducing interventions that are guideline recommended by established medical professional societies such as NCCN, the American Cancer Society, ASCO, and others. So what we see is more and more patients coming into the Medicare system or being part of the Medicare system, and they are unable to access guideline recommended care to prevent or detect their cancers early. We do know that Medicare covers certain preventive services, but those services are typically appropriate for people who are only average risk of cancer. Things like an annual mammogram or prostate cancer screening. And when it comes to the increased screening for high-risk individuals, such as a breast MRI, for instance, or a risk-reducing hysterectomy, Medicare is not permitted to cover those tests. So ultimately, individuals who are high risk are put in a bind. They learn of their increased risk and they're unable to access the guideline recommended care. This has come into play with a number of our constituents from around the country, and more we are hearing stories of families who are frustrated with this situation and not understanding why they cannot take advantage of the opportunity to be proactive with their health. This is why the Reducing Hereditary Cancer Act has been introduced. Again, it's bicameral, bipartisan legislation that aims to modify the Medicare statutes to allow for genetic testing for a hereditary predisposition to cancer for individuals who meet guidelines. So this is not population-wide screening. This is guideline recommended screening for individuals who have a specific family history or a known genetic mutation in the family. And then for those who test positive, it would allow Medicare to cover the guideline recommended downstream care. Things like advanced breast cancer screening or pancreatic cancer screening for individuals who meet the criteria for that. Risk-reducing surgery, while it sounds extreme, can be incredibly impactful, especially for cancers like ovarian cancer, for which there's absolutely no early detection or prevention. So we are thrilled to have Congressman Bouchon here with us. He is one of our leads in the House of Representatives. He also is a medical doctor and has, I'm sure, an appreciation for the value of utilizing medicine to its fullest extent to better the health of individuals throughout our country. So I'd like to welcome the Congressman and thank him again for joining us.
Well, thank you very much for inviting me to come. This seems kind of intuitively obvious, doesn't it? That this legislation should already be happening. To me, it does. It just seems like common sense, but unfortunately, sometimes in Medicare and Congress as a whole, common sense things don't necessarily happen. As was mentioned, I was a doctor before I was in Congress. I was a cardiothoracic surgeon for more than 15 years, and I saw firsthand, of course, the toll that cancer takes on patients and their families, and know just how critical early detection and prevention can be in the fight against this disease. The Reducing Hereditary Cancer Act, H.R. 1526, with my colleague Debbie Wasserman-Schultz, will help assist these efforts by increasing access to genetic tests, and some of this that I'm going to speak about you've already outlined, improving health outcomes for patients, and overall reducing healthcare costs. And that's a key. I was proud to introduce this bipartisan legislation to help facilitate access for patients and promote innovative efforts to combat hereditary cancers. It's bicameral, as was mentioned, with S-765, and bipartisan. Will expand access to life-saving genetic testing to determine an individual's risk of developing hereditary cancer. And this is something that our Medicare patients shouldn't be disadvantaged compared to everybody else. It's widely endorsed by patient advocacy organizations, academics, and medical institutions across the United States. And again, it will ensure that Medicare beneficiaries are able to access genetic cancer risk testing and take advantage of additional medically necessary, guideline-recommended screening and risk-reducing interventions. Under current law, Medicare only covers genetic testing for beneficiaries who already have cancer, and this is obviously personal to Congressman Wasserman-Schultz, as you probably all know. Regardless of their cancer history, it's still not covered, or a known genetic mutation in the family, which is the case with my co-sponsor. This is a problem, and because the knowledge of an inherited mutation can be life-saving for an individual and their family members as it guides decisions regarding cancer screening and prevention. These services are covered for most Americans with private insurance and Medicaid. And lack of access to these life-saving services helps exacerbate health disparities and adversely affect Medicare beneficiaries, Medicare, and honestly the U.S. healthcare system as a whole. With access to more early detection, individuals would detect cancer earlier when it is more easily treated, better understand their personal cancer risk for multiple cancers, and make informed decisions about the type and frequency of cancer screenings and inform family members about their potential cancer risks. So thank you for your advocacy for this legislation and for the issue as a whole. And I continue to look forward to working with all of you and with Congressman Wasserman-Schultz and our senators to try to find a pathway forward for this legislation. There will be a cost to it, and that's the situation. I think it'd be fairly minimal, but the way things work through at this point with CMS is we'll have to find an offset somewhere to cover the cost. But again, I've struggled with this with the CBO before, because I argue that if you early detect cancers and you find people at an earlier stage, it saves you lots of money. And that alone is so intuitively obvious to people like myself that the CBO should actually give us a favorable outcome. But unfortunately, they score things statically, what the cost is, and it's very unusual to try to get them to estimate future cost savings, whether it's this issue or others. I've gone around and around with the CBO director on this issue for for years, this CBO director and others. And hopefully we're making some progress. I would argue that healthcare legislation in Washington, D.C. that is good for patients, good for families, good for the country, are frequently stopped by these Congressional Budget Office scores because of the inability to project cost savings out into the future for each individual patient. But I'm going to continue to work on it. And so I really much appreciate you allowing me to give a few minutes of comments, and we'll see where we go from here. Thank you very much.
So to piggyback on that, the concern around the cost, just to share with the audience, we have commissioned an independent financial study that is being conducted by two well-known health economists, and we're hoping that that study will fully demonstrate the benefits of prevention and early detection versus the cost of treatment and the cost to the system. So we're hopeful that we will be able to share some data to help back that up within the next few months, and I'll be thrilled to share it with Congressman Bouchon as well. We are, I believe, waiting on a representative from Congresswoman Wasserman Schultz's office, and she has not arrived, so we're going to go ahead and get started with our expert speakers. I'd like to welcome Vicki Hood to make an introduction.
Hi, my name is Vicki Hood. I'm the Manager of Policy and Advocacy for the National Comprehensive Cancer Network. And I'm going to give you a brief introduction to Dr. Christina Annunziata from the American Cancer Society. Dr. Annunziata is Senior Vice President of Extramural Discovery Science at the American Cancer Society, leading a team of scientific directors and staff to identify the most innovative and promising research from research grant applications to end cancer as we know it for everyone. In addition to leading the grant peer review process at ACS, she builds and fosters critical relationships with cancer researchers across the nation and with international scientific communities. Dr. Annunziata has been a leader in innovative cancer research in the laboratory and in clinical trials. Her laboratory established the NF-kappa B signaling pathway as important for ovarian cancer stem cells and their progression. This work led to an investigator-initiated clinical trial using the SMAC mimetic class of drugs, which has now moved to a multi-center trial to test the efficacy of SMAC mimetic in combination with standard chemotherapy for patients with chemorefractory recurrent ovarian cancer. She also developed the field of intraperitoneal cellular immunotherapy. This is a type of immunotherapy where the patient's own cells are engineered to attack cancer cells. Since ovarian cancer grows predominantly in the abdomen, Dr. Annunziata reasoned that the therapy would be most effective if administered directly to the site of the cancer. She tested different types of cells in the immune system, both innate and adaptive, along with cytokines to support the immune cells. The next steps will be to combine the components to maximize their anti-cancer activity. In addition to her research, Dr. Annunziata has chaired scientific peer review committees for both laboratory and clinical research grant proposals. These include committees across the National Institutes of Health, the American Society of Clinical Oncology, and the Department of Defense. Prior to ACS, she was a senior investigator at and directed clinical operations for the Women's Malignancies Branch at the National Cancer Institute's Center for Cancer Research, including heading the Translational Genomics section. I'd like to welcome Dr. Annunziata.
I'm the Senior Vice President for Extramural Discovery Science at the American Cancer Institute, but I'm also speaking to you as a practicing physician. I still do see patients with hereditary cancers and otherwise in other cancers, men and women with cancers, specifically focusing on gynecologic cancers, of which probably 15 to 20% are related to an inherited genetic mutation. So cancer, as we all know, as the congressman mentioned as well, is a devastating disease, and it places a huge burden on the patient themselves, on their families, and on the healthcare system itself. So if cancer can be prevented, this would really take a tremendous amount of stress off of the patient, socially, medically, and also financially in the country, in the healthcare system. So as Lisa mentioned, there's several genetic mutations that are known to increase the risk of developing cancer. And those cancers include breast cancer, ovarian cancer, prostate cancer, colon cancer, many different types of cancers. The mutations can occur in the cancer themselves, but can also occur at the germline level. And what that means is that at the germline level, it's inherited, it's passed from the parents to the children, and it's in every cell of their body. So that puts the patient or the person at an increased risk, substantially increased risk of developing cancer throughout their lifetime. So if we know that somebody has this inherited mutation, there's more stringent guidelines, as Lisa mentioned, for screening for cancer in order to detect the cancer early. And there's also prophylactic measures that can be taken to prevent the cancer from developing itself. We can all acknowledge clearly that cancers detected early are much, much more treatable than those diagnosed at later stages, and some can even be cured if they are found at an early stage. But even better is if you can prevent the cancer from even happening by taking prophylactic measures. That would also that would reduce the burden even more if the patient just didn't develop the cancer. So the important points that I wanted to highlight in this discussion are, number one, the testing for carrying of a mutation, of an inherited genetic mutation that increases a person's risk of developing cancer, and then also the proper intensive screening to prevent the development of cancer or to detect it early. So you might ask, why do we need to test for genetic mutations in patients with Medicare? In the Medicare age population, what's the point of testing? So shouldn't they already know that they have cancer? So the answer is no. So we typically think of hereditary breast cancer as occurring in women under the age of 50. But for ovarian cancer specifically, the age is much, much later at time of diagnosis. And in fact, for some of the known mutations for ovarian cancer, the average age of diagnosis is 62 to 65 years old. So that is the Medicare population, and that's who we need to test with the genetic testing. They are at risk even if they haven't yet developed a cancer. And so why is it important to find these mutations? Of course, we need to know so that they can take appropriate measures. So the second issue that I mentioned is, what are these appropriate measures? And these include both increased cancer screening, so not just the typical guidelines for the average risk population. These are more intensive screening, including CTs, CAT scans, MRIs, sometimes surgical biopsies, and then prophylactic measures, which can be removal of organs that are at risk for developing cancer that we know are associated with a particular mutation. So that is the background of the reason why I feel strongly about this test. From the American Cancer standpoint, American Cancer Society standpoint, we know that as oncology innovations continue to be advanced and come to the market, it's critical that we do address barriers to timely and affordable access for cancer patients and those at risk for developing cancer. So lack of sufficient coverage for a particular service like genetic testing or prophylactic surgeries does create a barrier for an individual. And the American Cancer Society supports this Reducing Hereditary Cancer Act in order to address this particular barrier. In addition, knowledge of inherited genetic mutation can empower the individual to better understand their personal risk of cancer and make informed decisions about their health. So this Reducing Hereditary Cancer Act refers to evidence-based and guideline-informed testing. And we believe that these provisions are important for all Americans to access to reduce the burden of cancer and to achieve the vision of the American Cancer Society to end cancer as we know it for everyone. Thank you.
Dr. Tuya Pal is a professor of medicine and an Ingram Professor of Cancer Research at the Vanderbilt University Medical Center, where she's also the Associate Director for Cancer Health Disparities at the Vanderbilt Ingram Cancer Center. Her research efforts have a broad focus on cancer health disparities spanning across basic and clinical services, as well as health services delivery in diverse populations and healthcare settings. She currently leads multiple studies focused on genomics, outcomes, and care delivery among underserved and/or inherited cancer populations. She is also the vice chair of the National Comprehensive Cancer Network's Genetics and Familial Guidelines Committee for Breast, Ovarian, and Pancreatic Cancer, as well as the editor-in-chief for the National Cancer Institute's Cancer Genetics PDQ editorial board. Please welcome Dr. Pal.
Thank you, Vicki, for the kind introduction. So as Vicki mentioned, I'm just trying to get into the slideshow mode. You might have to do it up top here. Right here, right? Okay, perfect. Yeah, so it's a real pleasure to be here. My name is Tuya Pal, as Vicki mentioned. So I wanted to start off, and I think you have a great background for what everyone has already highlighted. This is kind of a no-brainer, but I wanted to lay it out similar to how everyone else has done it. So why do we want to identify inherited cancer genes, such as BRCA1 and BRCA2? And I'm going to focus on BRCA1 and BRCA2, not because they're the most important, but because it serves as an example to kind of walk you through where the gap is, what this means. So knowing about inherited cancers can save lives if you act on this information. So we know that the BRCA genes were identified about 3 decades ago now, right? But when we look to see what has happened, we estimate that about 10% of adult female BRCA carriers have been identified at this point. So we have an identification problem, right? And most of these individuals do not yet have cancer. And this under-identification is even more of a problem in populations that have historically been underserved, such as the Black population or the Hispanic population. And we know that, we've shown that with data. So when someone has a BRCA mutation, what that means is that their risks of cancer are higher, right? So for breast cancer, it would be in the range of 60 to 70% compared to about 12% in the general population. For ovarian cancer, it's somewhere between 20 to 40% compared to less than 2% in the general population. And we have guidelines to either detect cancers early or prevent them altogether. So for breast cancer, what we recommend per the NCCN guidelines is heightened screening through both breast MRI as well as mammograms, and the option for risk-reducing mastectomy. For ovarian cancer, what we recommend is removal of the ovaries and the fallopian tubes, because that is the only way to detect or to prevent ovarian cancer. Screening is not something at this point that's been shown to be reliable. So I just wanted to point out here that testing itself doesn't save lives. It's really acting on the test results that can save lives. So while we are saying that these people need to get tested, they also need to have access to the follow-up care following the testing. So I always find it useful to focus on a case, and this is a real case of mine. I'm a clinical geneticist by training, and I'm one of the physicians in our hereditary cancer clinic at Vanderbilt. So here we have a patient with the black arrow, a 28-year-old who meets NCCN guidelines for testing. And the reason she meets the guidelines is her grandmother had breast cancer, 2 separate breast cancers, one in her mid-40s, one in her early 50s. So that in and of itself is enough to meet guidelines for testing. So she's tested and she's positive. She has a BRCA2 mutation. So just wanted to mention a few things about the NCCN guidelines. NCCN was formed in the mid-90s to develop national standards of cancer care in the United States. And it is the recognized standard for clinical policy in cancer care. It is the basis for insurance coverage policy. And there are strict policies to shield the guidelines development processes from external influences. And again, this is a busy slide, but all this to say there is a stringent process around developing and updating the guidelines, where we have an annual institutional review and then a panel meeting where updates are discussed, reviews, and then the updates are posted. And because the science is moving so quickly, we have opportunities to update the guidelines in the interim. And I'll tell you, for the panel that I'm the vice chair of, I think we're on our third update already for this year, and we just released them like 2 months ago. So again, it is a very active process, and there's a lot of people that are involved, and they're experts across the country that contribute to the guidelines development. So going back to our case, what this means is we have this BRCA2 positive woman, age 28, but let's think about her mother. So her mother is age 65. That means that she has Medicare, which also means that the testing is not covered. And if she's positive, risk management is not covered. So going through this Medicare gap, and I know you've already heard this from all of our other speakers. So if you're with insurance below the age of 65, testing according to guidelines is covered. Cancer risk management, if you're positive, is covered. So screening or risk-reducing surgeries. And these are based on evidence-based guidelines. We've shown this in the scientific literature to be efficacious. Once you reach age 65, neither of these is covered in individuals without cancer. So the thing is, testing is covered if you have cancer. But again, we're kind of behind the game when someone's developed cancer. And really, this is something Lisa mentioned. We're focusing on testing for high-risk individuals. We're not talking about population-based testing here. And we're talking about testing for inherited mutations. So not the tests like liquid biopsy tests to follow cancer recurrence. So this is different. So going back to this case again, let's look at the patient's aunt, who's 63. Now, she has private insurance. Her testing is covered. And if she's positive, her risk management is covered, but only till 65. So again, what this means is individuals without cancer and if you have private insurance, your testing is covered up until age 65. And if you're positive, screening and preventive surgeries are covered. However, once you reach the age of 65 and you get onto Medicare, your testing is not covered if you haven't already been tested. Even if you have been tested and you've been getting your screenings are no longer covered at age 65, nor is any prophylactic surgery. And we know lives are saved with preventive surgeries and screening. We have proven that with the scientific literature. So I wanted to kind of walk through a case, and I know there are some economic modeling, but again, in my mind, with using BRCA as an example, we're saying 20 to 40% lifetime risk. Most are diagnosed at stage 3. What that means is it's spread beyond the ovaries at diagnosis. We have no form of early detection. So really the only option here for cancer prevention is removal of the ovaries and the fallopian tubes. About half occur after age 65. So this is the Medicare population. And average 5-year survival is about 50%. So I just wanted to do an exercise here. Say we have 10 BRCA carriers, about 3 on average will develop ovarian cancer, right? So treatment, again, estimate, $100,000 a year. So that gets us to about $300,000 a year. If we're saying about 5 years, we're already at 1.5 million. Let's think about if we were able to prevent all these cancers and we covered the preventive surgery. And again, an estimate, about $20,000 one time. So that's a total cost of $200,000. So the cost savings here, and again, this is a complete estimate, but it's over $1 million is what we think it probably would be. So here's something that would save cost, and it would save lives. I mean, more important to me is the saving lives, but it also saves cost. So again, I do think this is a no-brainer. With BRCA carriers, and this is across other inherited gene mutation carriers, like people that have other inherited cancer genes, they shoulder a disproportionate cancer burden. So really, they're the poster children for cancer prevention, or the low-hanging fruit, if you think of it in that way. And we also know that preventing cancer is better than treating someone and trying to cure them once they've developed cancer. So, so just some closing thoughts. The coverage gaps, I haven't really touched on this in any detail, but we know that all populations aren't getting tested. All populations don't have the same access to care. So what's going to end up, we know that with genomic testing, there are disparities. This is going to widen existing disparities, right? Because those without a means to pay are going to be the most affected. And access to follow-up care is critical to save lives. It's not just about the testing. We have to cover the follow-up care. Otherwise, the testing is useless. And the gap addressed by the Reducing Hereditary Cancer Act is to cover testing according to guidelines, so not just population testing, it's testing for people based on risk stratification, cover screening and prevention in BRCA positive patients or patients more broadly with inherited cancer predisposition due to several different genes. And these costs are already covered by private insurers. They're already covering this. And that's based on existing evidence-based guidelines. So with that, thank you for your attention. And as one of our founding fathers said, an ounce of prevention is worth a pound of cure. Thank you.
Oh, that was wonderful. I'd like to welcome up a representative from Congresswoman Wasserman Schultz's office, and she is here to share some remarks on behalf of the Congresswoman.
Good afternoon, everyone. Thank you all for joining us. I'm Tracy Pugh. I'm the Congresswoman's Chief of Staff. I've been with her for 18 years now, so a long time. And I'm sharing her remarks today because she would love to be here, but she's just leaving the March for Israel rally and headed into a classified briefing on the conflict, which I don't know if you guys noticed is, oh, hey Tammy, is right down the hall. So again, she sends warm love and support of all that you all are doing here today. And obviously she continues to be a champion to address the issues that we all care about. So first, she wanted me to thank the National Comprehensive Cancer Network and FORCE for coming together with our office to host this important briefing on reducing hereditary cancer. Patrick, who many of you work with in our office, and thank all of you for supporting our recent Cancer Survivorship Summit that we held in the Congressional District with First Lady Jill Biden. We also had the Secretary of the VA and many cancer survivors and medical professionals from across the country were able to address our constituents. It was an exceptional event, and I believe that our constituents really benefited from all the information that was shared. So thank you to everyone that participated. The work, vision, and leadership that you all are providing on the bill that our office is sponsoring is really helping to drive it forward. And the Congresswoman also wanted me to give a very special thanks to the co-leads on our legislation. This is a bipartisan effort. Representative Miller Meeks, Slotkin, and Bouchon for their endless support on the bill. We're all working together to ensure access to genetic cancer screenings. So I want to tell you a little bit about Debbie's story. it still is really fresh in my memory, even though it's been over 16 years. She was diagnosed with breast cancer, and like many Ashkenazi Jewish women, she discovered that she carried the BRCA2 gene mutation. So after 15 months of surgeries and treatment in what was a very difficult, and she chose to keep her cancer battle private until she was done with all of her treatments and could come out. And many of you are familiar with the Early Act that she sponsored after going public, that she was cancer free. Her journey of survivorship really helped translate her diagnosis into something greater. And throughout all of her professional career, since her days as a Florida legislator, she's been a strong advocate for education, awareness, early detection, prevention, and survivorship. And many priorities in her policy agenda are also aimed at protecting access to early screenings, one of the best tools, as many of you have already discussed today, that we can use to beat this disease. Unfortunately, as you all know, there is a lingering barrier to coverage for preventative care for hereditary cancer. Under current law, Medicare covers genetic testing. I was literally texting Patrick as I was sitting back here, and I was like, this is crazy. What's going on with Medicare? He was like, that's why we're filing our bill. So, under current law, Medicare covers genetic testing only for beneficiaries already diagnosed with cancer, regardless of family history or known genetic mutation in the family. And this makes absolutely no sense. If you have Medicare, you cannot get a genetic test until you already have cancer. It just makes no sense to me. As so many stories show, and the example that we just saw, it is vital that we address cancer through early detection using all the tools available. So the Reducing Hereditary Cancer Act addresses this gap, and it ensures hereditary cancer screening and follow-up coverage. This is, as I mentioned, a bicameral, bipartisan bill that would require Medicare coverage of the genetic testing for inherited mutations known to significantly increase cancer risk for those with a known hereditary cancer mutation in their family, and those with a personal or family history of hereditary cancer. And for those who inherit a mutation causing a moderate to significant increased cancer risk, this bill would enable Medicare beneficiaries to get increased coverage for screenings and risk-reducing surgeries. With access to early detection and the realization that someone has a mutation, individuals will be able to better understand their personal risk for multiple cancers and make informed decisions about the type and frequency of cancer screenings. So in closing, I just want to say that Debbie Wasserman Schultz is and will continue to be a champion. She is very grateful to all of you for your support of this legislation. Looking forward to working with you as we look to move this through the legislative process. And I want you all to know that I think many of you that work with our office in particular, you know that even though Patrick handles healthcare, which is a huge portfolio for the congresswoman for our office, he's based in South Florida, but he's always accessible, and we want to be partners with you and working with you on this issue in particular, but on the many issues that your organizations champion. I believe that together we can continue to deliver for cancer survivors and their families, and this bill will create another tool in our fight against cancer. So thank you so much, and like I said, on behalf of the Congresswoman, we are ready, willing, and more than capable of working with each of you in this fight. Thank you so much.
So as we've heard today, there are a number of stories that we've learned about from individuals who have encountered barriers to care. And we have a patient story that we would like to share with you. Unfortunately, she lives across the country in Oregon. So forgive me while I try to pull up this meeting here. And so she'll be joining us by Zoom. There she is. All right. I am pleased to welcome Margie Harris. She is coming to us from Portland, Oregon. And Margie, can you say
You're on mute. No, she's fine. You're fine. She's fine.
Margie, let's test your audio.
I'm trying to test my audio. Can you hear me?
Yes, excellent. Okay, thank you, Margie. I'm going to let you take it away here.
Recording in progress.
Okay, thank you very, very much. For the record, my name is Margie Harris, and I live in Portland, Oregon. In early 2022, I had a genetic test and learned that I carry the BRCA2 gene mutation. There is a strong family history of cancer on my father's side, and when my 36-year-old daughter underwent genetic testing, I learned that she carried the inherited genetic mutation. That explained why cancer is so very prevalent in my family. Medicare did not cover the cost of my genetic test because it only covers the service if you already have cancer. And Medicare does not cover genetic testing if the purpose is to inform cancer risk. The BRCA mutation greatly increases my risks of getting 3 cancers during my lifetime. One is breast, one is ovarian, and the third is pancreatic. Fortunately, the American Cancer Society and the National Comprehensive Cancer Network issued specific guidelines for people with BRCA and other inherited mutations, specifically enhanced screening and risk-reducing interventions. I pursued these recommendations to help reduce my cancer risk. I had my ovaries and my fallopian tubes removed because there is no effective screening or early detection for ovarian cancer. I enrolled in a high-risk breast cancer screening protocol, and I am also part of a national high-risk early detection study for pancreatic cancer. I'm extremely grateful for the outstanding care that I receive to help manage my cancer risk. My healthcare professionals believed, as did I, that the cost of these treatments would be covered by Medicare. This was not the case. My providers submitted 20 detailed claims to Medicare totaling nearly $19,000. Of this amount, Medicare denied nearly $15,000. I was alarmed by these denials and the potential financial impact they would have on me as a senior citizen and as a retiree. I was afraid to open Medicare summary notices and see the word no in big, bold black letters on every page. The stated reasons why Medicare denied my care were inaccurate, and they did not reflect the true purpose of my treatments. Why would Medicare label consultations about options to reduce my cancer risk routine? How could the removal of my ovaries and fallopian tubes be described as cosmetic, or worse yet, sterilization for someone who is a 71-year-old woman? I spent months engaging with Medicare representatives trying to understand why these denials were made, and I never got a satisfactory explanation. It was incredibly stressful. When I connected with Force, I learned that current Medicare policy actually forbids the organization from covering these high-risk screenings and preventive services. That is why such claims are commonly denied, and that is when I determined I needed to file a Medicare appeal. This is my paper file from my research and my outreach. I was lucky because based on my appeal, Medicare ultimately reversed the majority of its prior denials and did make payments. That then enabled my supplemental health care insurance to kick in. For a host of reasons, I presume Medicare members who do have hereditary cancer risks like mine would not do what I did. I had the time and the stubborn tenacity to prepare a Medicare appeal. I was motivated by the principle that my care and the health care of other hereditary cancer risk patients like me should have been covered by Medicare. And those with private insurance and Medicaid do get insurance coverage for this care. But when they become eligible for Medicare, like my daughter, who carries this gene, will be someday, that coverage will end. Why are those who are covered by Medicare discriminated against and denied the critical care that reduces our cancer risk? Cancer screening and risk reduction interventions are many times less costly than treating cancer itself. I believe Medicare should help hereditary cancer patients reduce their risks by allowing coverage of guideline-recommended cancer screenings and interventions. Please advocate for this critical change. Thank you to Lisa, to Force, and thank you for listening.
We're so appreciative again that you joined us today to share your story. We're going to move on now to a Q&A that will be hosted by Alyssa Schatz with NCCN. And Margie, we'll talk to you again soon. Take care.
Thank you.
I want to open it up to the audience in case there are any questions. We have just a few minutes left in the briefing, but we'd love the opportunity to answer any questions the audience might have.
Sure. Hi, I'm Tiffany Haynes. I'm here on behalf of Living Beyond Breast Cancer. And so as a patient advocate and working with the organization, what are things that we can do, I guess, to help advocate and help push this forward?
I think, there we go. That's a great question, and I think we can address that from two angles. One is through the advocacy angle. So we value our partnership with Living Beyond Breast Cancer and many other cancer organizations. If those organizations can support us, which LBBC already has, but more importantly, we need individuals to reach out to their lawmakers and to let them know how important this legislation is and why we need to ensure that this coverage is available to anybody, no matter what their insurance is, regardless of age or cancer status, and that it has implications not just for the Medicare population, but for their children, their siblings, and the rest of their families. So we would fully ask for your support, and Force has information about this that is on our website and we can share. I would also say from a medical perspective, maybe one of the doctors can speak to how important it is to talk about family health history and to share that information amongst family members.
And Lisa, before we dive into that, I just want to also quickly note one other specific request that we can make of lawmakers is for co-sponsorship of the legislation.
Yes.
We're currently looking for co-sponsors in both the House and Senate versions, so that would be great.
So So yeah, like Lisa mentioned, once someone is identified in genetics or in medicine, when we're talking about inherited disease, the patient isn't, we don't think of the patient as the only thing that we're thinking about. Like, our unit of care is really the family. So once these individuals are identified, it's almost cascading to the other family members. And if those other family members are 65 and above, we're kind of stuck because they don't have coverage. So I do think just pointing this out, and when we're talking about family health history, this is something, even with USPSTF, they came out with guidelines that family health history should be screened at the primary care level to identify individuals with BRCA and other inherited cancers. So again, I think raising awareness is important.
I would also add that in some families, certain individuals have concerns about pursuing genetic testing, and so presenting them with information about how to connect with a genetic counselor and the value of being identified and the different options that a person has if they're at increased risk. It's not just surgery. There are choices, and the goal is for the individual to make informed health decisions that are appropriate for them. So that's something we also try to emphasize.
That's a great point. Do we have any other questions from the audience? Yes.
Hi, I'm Sue Rahman. I'm a volunteer with FORCE. I actually had a question about the Preventive Services Task Force and what their guidelines are around hereditary cancer testing. So thank you for confirming that they have something, but is it mainly around breast cancer?
So for years, the USPSTF guidelines for hereditary, like BRCA1 and BRCA2 came out quite a while ago. I don't remember, but it was many years ago. For years, there was this, 2013, Lisa knows. But for years, there was this gap where if you didn't have cancer, it wasn't like, it didn't matter. They weren't recommending testing. That actually changed a few years ago. So that gap has closed with USPSTF, yet it remains in our Medicare population. So just because, so USPSTF is recommending that individuals at high risk, including those who have not had a cancer diagnosis, get genetic testing if they meet guidelines.
And for BRCA specifically, there are other areas of risk as well, correct?
There's absolutely yes, there are. And but you bring up USPSTF, the other gap is we have these for BRCA, but what about all these other genes that also raise risk, right? So the most common form of inherited colon cancer is due to the Lynch syndrome genes. And we don't have any USPSTF guidelines around that. So again, I think there are huge gaps in care for many individuals across many different cancer types.
And I'll jump on that just by adding that our organization did request that the task force develop guidelines for hereditary cancer, colorectal cancer screening, to develop guidelines for Lynch syndrome, which is involves 5 mutations that cause increased risk of colorectal cancer, as well as endometrial cancer and others. Initially, the task force said that it would take that on, especially with the skyrocketing rates of earlier onset colon cancer that we're seeing in the U.S. population. Unfortunately, we recently heard back from the task force that they lack the resources and the bandwidth to develop those guidelines at this time. So it's not for lack of necessity, but more of the inability based on manpower, resources, or anything else for the task force to address this issue. Still, Medicare has the opportunity to close this gap regardless of the task force, which currently does recommend BRCA genetic testing.
So I know we're getting toward time, but I want to check and see if there is maybe one more question before we wrap up.
Hello, my name is Kabora Issa. I'm a freshman political science major at Howard. And I want to ask both of the doctors, what patterns of hereditary cancer do you see in Black women? And how can we ensure that this act impacts them and benefits them as much as other populations?
It's a great question.
So I can just start briefly. The cancers in the Black population tend to be more difficult to treat and tend to be detected at later stages. So this is a very important point that this act potentially can address in the Medicare population, specifically allowing and encouraging Black women to get tested. There does need to be additional discussion and additional advocacy in that group. Absolutely, we need more equity in that area, specifically women with endometrial cancer, which can be hereditary, ovarian cancer, in that area, and colon cancer. Those are the three main ones that tend to have a worse outcome in Black women. So we absolutely need more advocacy in that area.
So I'll just briefly address it. This is actually an area of my research, young Black women with breast cancer. And again, in the past, say 15, 20 years ago, when the original studies came out, there was this feeling that, oh, well, BRCA mutations aren't as common in Black women. That's not true. And if anything, our research has actually shown it may be more common. It's not just our research, it's research coming out of the African population from West Africa that's also shown that. So again, the jury's out, but at least the same, if not higher incidence, right? The other thing is, breast cancer, if you look overall, all comers, the risk in Black women is a little lower. However, when we look at women below the age of 50, the incidence is higher. So there's this disparity right there, and they tend to get triple-negative breast cancers. Triple-negative breast cancers tend to have a higher inherited fraction. So yes, I think focusing on certain populations, there could be additional benefits. I think overall we need to give care across all populations. I think that is our goal. When I started my research, people were saying, oh, well, Black women, they don't want to get tested. That's not true. If you make it easy for them, if you make it accessible for them, if you explain it to them, most of them are interested at the same rates as other populations. So yes, I think this legislation, and I said this in my talk as well, if we're thinking about the Medicare age population, so age 65 and above, people with means are still going to get the screenings. They're still going to get the surgeries because, either they're going to be like our patient and very proactive, or they'll pay out of pocket. But it's the people without means that are going to suffer. So we are going to increase the disparities. So I think we need to keep an eye on our disparities lens. So thank you for the question.
Well, I just want to say thank you so much. I want to thank our incredible sponsors of the bill, Congressman Wasserman-Schultz, Congressman Bouchon, Congresswoman Slotkin, and Congresswoman Miller-Meeks. We're so grateful to their offices and all of the sponsors. And I also want to say thank you to our fantastic speakers for being here today. And thank you to all of you for taking time out of your day to come and learn about this important issue. We appreciate you and appreciate your advocacy. Thank you.
We'd also like to thank our Senate sponsors,
yes.
Senator Murkowski and Senator Cardin, and hope that we can work more closely with them to get this bill moving forward more quickly in the Senate as well. Thank you.